Landlocked within southern Africa, the Kingdom of Swaziland is a stable country, renowned for its green hills and pastures and its mild climate. But the population of just over 1 million is fighting an immense battle in silence against two deadly diseases that have joined forces to take thousands of lives every year: HIV/AIDS and tuberculosis. 1 out of 4 adults is infected with HIV, and among the 20,000 who develop tuberculosis each year, more than 80% are co-infected with HIV. To make things worse, there's also a significant number of cases of drug-resistant tuberculosis, which are much more difficult to manage and take longer to cure. As a result, over the past 2 decades, life expectancy in Swaziland has dropped dramatically from 60 years to just 31 years. Parents have died, leaving children orphaned, and the workforce is slowly declining. Efforts by the authorities to tackle the emergency are hampered by an acute shortage of medical staff, as well as inadequate means to diagnose the diseases accurately, and patients who fail to complete or continue their treatments for various reasons. Amongst these are the long distances to and fro from the clinics for treatment, and the high financial burden associated with the cost of the trip to the health facilities. In 2007, international humanitarian organisation Médecins Sans Frontières started to work in Swaziland, providing support to the Ministry of Health in Swaziland, one of the country's poorest and most remote regions. To fight the dual epidemic of HIV and tuberculosis, new and innovative strategies were put in place with a decentralised, integrated and patient-centred approach. The result is increased numbers of patients diagnosed and initiated on treatment earlier, better attention and care and improved treatment outcomes. Much remains to be done in the fight against HIV and tuberculosis in Swaziland. The following interviews with health staff, patients and MSF volunteers highlight the challenges, constraints and possible solutions to improve access to HIV and TB treatment and the management of infected patients in the Kingdom. These personal perspectives on the threat that TB currently represents and the call for increased emergency measures to be put in place give a clear picture of exactly why MSF decided to start up operations in Swaziland.
Before MSF came into this region, TB services were only accessed at the health centers in the cities. But when MSF came in, we've started decentralizing services to the periphery, to the smaller clinics in the rural health center. This has helped a lot, as people can easily go to their nearest clinic. They don't have to get buses to come into town, and drugs are readily available from their clinics. They can go there for screening, they can go there for testing. Treatment is easily accessible. People do not have to look for money to get buses to come into town.
Mina into engayisho i-MDR iyalapheka yona, kepha wendlula etigabeni netigaba. Kube bekangekho MSF angisupporta ngemali yekuthi ngiyemtholampilo ngabe angikakhoni futhi ngabe ngifile. Ngabe angakhoni lokuyojova. Ngoba make vele abede kwale mali ngalesinye isikhathi ukhande kwekuthi ngiphethwe ngiletinyawo angikhoni ngisho kufika lapha e-station kulikhuni cishe ngathi hayi sengehlulile MDR hayi ngehlulile.
For drug-resistant TB patients, the duration of treatment is long. They take injections for a period of 6 to 9 months or even more, depending on whether the sputum convert or not. As a result, some patients stay at far away places such that they don't access clinics. They have to travel long distances. They need transport money in order to reach facilities. As MSF we have introduced a community-based concept whereby a patient selects an individual living within their catchment area, somebody living near to the patient's homestead, and we call those people community treatment supporters. For community treatment supporters, they've got a duty of ensuring that patients are there to treatment, and they undergo a certain period of training whereby they are also expected to give injections to patients in the homesteads.
Mina-ke ngifundile bangicela ukuthi bacela ngofunda ku Jova fikile ngahamba ngayofunda enhlangano emalanga lamabili ngifundiswa udokotela abanganamngcele bangifundisa kujova sengibuyile bangilandelela ke bazohlola ukuthi ngijova kahle yini ngendlela abangifundisa ngayo babeke seba abasezi kanjalo njalo kuzongihlola ngathi nasengibona bangachamuki ngacabanga ukuthi akushothi kumbe vele sengidla kahle ngendlela labangifundise ngayo sebeza nje bangilandelele ngalelo langa.
Another aspect in this mission which is very interesting and challenging is the task shifting, because with the number of patients affected by HIV and TB, it's clear that the normal health system now cannot cope. I'm sure that in my country, in Swaziland, if we have so many HIV and TB patients, we will not cope as well. So we need to imagine other way to deal with the number of patients. We are doing that for quite a long time now, and it's really working. For example, we have patients. We have people only focusing on reading the slide to detect the TB in the sputum of the patient, and that means you can have a high number of slides seen by these people, and like that detect more TB patients. And if you detect more TB patients, this patient will not infect other patients. So it's like that we are going to try to decrease the number of TB patients in the country and win the battle against TB.
It has been found that the place where most infection occurs is actually in the health facility as compared to in the street or anywhere else. And those health facilities where they have 1 or 2 nurses only and no farm technicians, you find those are very, very crowded. These are the areas where there's need for infection control measures, simple measures such as opening of windows, simple measures such as cough triage, separating those people who are more infectious, whom we suspect have TB. Those people should go in and see the health practitioner first. We also need to engage all the healthcare workers to teach the community and know about TB and know how it's spread. That's the way to prevent it.
And I was sick. They know that I was sick before, but now I look fine because of the treatment. And they really understand me when I'm saying that this TB treatment can cure MDR. TB in Swaziland is the most dangerous disease, which is killing people, old people, young people. I'm fine. I'm feeling well now. I'm about to finish my treatment.
There is crisis in the country. We cannot run away from that. The reality on the ground is that there is crisis and there is need that it be declared as a national emergency.
TB in Swaziland should be declared as an emergency. At
the moment where we have the feeling that it's kind of denial about the very severe situation in Swaziland with TB and HIV.
We have succeeded in a lot of the things that we have done. I'm very proud of some of the things we have done and the advocating that we have done. But I feel we need more and more, and especially from our ministry.